This is more.
Even the youngsters like you get a little amnesia.
Hopefully it'll be our last time.
Not really. I was busy.
You were a career person by then, and we're not experimenting with LSD.
Have to be. Of course, I'm not now.
Right?
That's trust.
All right, I'm going to just pause our conversation, get things lined up here.
And there's the 3 dots.
Yes, they are. Yeah, that part's the same for sure. I have another surgeon with me, Dr. Kuhn is here, so we might be talking a little shop. Is that okay with you? How's your comfort level with the instrumentation for the incisions?
Feel it?
Has it? Yeah, because there's more tactile feedback. Good.
Right.
Yeah. Yeah, right. Well, I think go as far back as possible, but of course, you know, if you get into the conjunctiva, then you get a bleb, and that's never fun. That's good. You can always just do a little peritomy area, and then it does, you know, it'll drain. I had a patient this morning who had like a little temporal pterygium, and growing onto the cornea, it's like you know that's going to blow up. So I took the pterygium off real quick. Use the same one. I mean, I just use 0.12s in Westcott to take off the pterygium. But I'm thinking, like, you know, maybe it'll get a little red, and I might need a little 5FU in the office. I don't know. It's basically just like a bare sclera technique with no anti-metabolite. Kind of worried, but it recurs, and there wasn't any expectation of a pterygium removal. It was just kind of in the way. No, they're not bad. They're right. Hey, Liz, try to find the 3 lights. Good, you got them. I think you have to at least go in the center of it, but see, I can see that it's split all the way through, right? I mean, that thing is pretty sharp on the bottom, so you don't want to approach the posterior capsule. But they do split really easily. Easier than I thought. I haven't done any really hard lenses yet with it. And then I can go right to the conner. Yeah, and you can just advance me right to segment, honestly. Or I can do it. I'll do it with my foot. Drew was telling me they have a different phaco tip called their mixed tip, which is like, basically sounds like a flared tip where it's a little wider at the mouth and has a thinner spot that can reduce flow. Uh-huh. Do you have to change the settings when you use it?
The flow restrictor, you can.
I wouldn't mind trying it too. Are they really expensive? Ah, perfect. And you can just use the same sleeve, so you don't need to change your incision size? That's good. Are we ever going to see you again?
Yeah. I do Sacramento, but
Is there a direct to Eugene from Sacramento?
there isn't. So go to the direct food.
Oh well.
There's a goes through Seattle.
Layovers are no fun. Although Seattle has this Sub Pop store that I like to stop into that has like records and cassettes. Lots of good food there, yeah. Yeah, I was in San Francisco last night and they were like that too.
Yeah.
Just a short layover, 30-minute layover. Stopped for food and almost missed my flight back to Eugene last night. Paging me overhead. Paging Dr. Neal. When I've got this degree of cortex, Julia, it doesn't make a ton of difference this sweep. But since it's in my hand, I'll make an effort. We're taking the cortex on the one side. And then we'll use the lens to squeegee the back of the capsule to make sure there's no epithelial cells. Maybe I'll just polish up the anterior rim here. Found a little string. And then I'll go across, grab the other side. We'll squeegee from the other direction. Focusing down. With the lens there, I can vacuum even right against the capsule pretty safely. Then I'll rotate the lens about 90 degrees. Come and save my soul. And then we'll get the sub-incisional. We'll squeegee this way. This is pretty tempting, so I'll just grab that real quick. And we got one more sector. Oh, let me grab a little polish on here. Then we'll go over here. There should be a little cortex in here still. No, not so much, but we'll squeegee from that direction. With a little tension on the capsule, I don't have to worry about working right next to it. And then there's probably still some cells under the lens. Right here, here. There's a little bit right there. Okay, so it looks like the PC is all clean. No, I just do it all on IA. Yeah. So then I was kind of focused down, right, to see the posterior capsule, and now that I'm kind of focused up, I can see there's still some epithelial cells on the anterior capsule rim. Pretty good, but now I want to inspect the ends of the haptics. With this lens, they have bulbs on them. You can see that there's some crud back here. And it's really important to get the haptics clean because, especially in your post-refractive, the power's not always correct. And if you're going to go back and exchange, you don't want any fibrosis on these haptics. That's that one. This one, I'll probably have to dial it, get a better angle on that haptic. That looks nice and clean, right? There's a little bit on there, right? Now I'm confident that the lens is really clean. I don't have any visual cortex in the bag. And all we've got to do is center it up. What's our axis? 66, okay? We'll try to leave it around 70 or so, just because we can rotate it clockwise a little bit if we need to, right? I'm ready to come out, finger on there, come out wet. Just bending it toward the bevel. Now look at the 3 lights.
Not really 3.
Well,
There they are.
you try to focus on those 3 lights. For just a little bit of hydration in there without blowing up the central cornea will allow the incision to seal. Back, please. A little bit more. As close to the epithelium as I can without coming through. There you go, and that's sealed up tight. We check the para. That's sealed, so it doesn't even need to be hydrated on that one. Now, if you look at the 3 sugar cubes there, and we'll take the angle marker, the 66. Yeah, exactly, the first Purkinje. So I'm lining up with kind of this point here and that point there. My 0 point, right? Then 66. So if I make a little nick at the limbus right there, usually I'll break a little blood vessel. Like when you want to break a blood vessel, you can't. One over here too. And kind of trying to line it up with the optical center, not necessarily the geometric center, but the part she's looking through, right? 66 will be right about here. There we go, so I got a little drip there. Okay, so now I've got 2 marks. And now look at the space between the 3 lights. Oops. Try to keep them on for you. So to do the direct puncture, it really helps to push down on the speculum. Irrigate, please. Okay. Look at the space between. Space between the lights. So you kind of see it needs to just move like a little bit nasal and a little bit inferior. Maybe just like that. And then I'm looking at my hash marks, which I think maybe this needs to go this way. I don't know, I feel like I might take another look and see if I really got those. Because if you connect the line, it doesn't really pass through this optical center so much. Let's see the angle marker again. Measure twice, cut once. 6. Yes, I think it's probably most like right about there, but it does need to rotate just a smidge more. The eye's a little soft, so you just direct a little flow in here to firm the eye up. Doesn't want to rotate counterclockwise, does it? Right? That's the way it goes. Like kind of pulling it toward the center should allow it to. Hey, look at the space between the lights, Liz.
Mm-hmm.
I feel like the axis is about perfect, but the lens needs to move toward her nose, obviously, right? So if I can translate it that way without rotating it, I'll be in the right spot. visual axis. Yeah. Yeah, I think it's really important to line it up on the part that they look through. So now it's centered on the light reflex, and if you connect the dots between the hash marks, they're parallel to my marks. That's correct axis with good centration. And that's done. Oxydex goes in through the main. Look down, Liz. You will feel a little sting here. I'm just going to say sorry before I do it. Keep looking down. I've kind of got it down there, and then I'm like,